Good afternoon and welcome to today's special webinar on pneumococcal disease. My name is Ian Colbert and I'm the Executive Director of the Canadian Public Health Association, and I will be your moderator today. And while we're gathering from all parts of Turtle Island, I would like to acknowledge that I am joining from my home in what is now known as Eastern Ontario on the unceded, traditional and unsurrendered lands of the Algonquin Anishinaabe. I also want to thank Merck Canada for the unrestricted educational grant that is making today's webinar possible. This webinar is being recorded and will be made available to all registrants after the afterwards, and you will all receive a notification when the recording is available. If you wish to ask a question at any point, you can enter it in the Q&A module at the bottom of your screen, and we will have some time reserved at the end of today's webinar to answer those questions. So without further ado, it's my pleasure to invite today's presenter, Dr. Ron Grossman, who is a professor of medicine at the University of Toronto and former chief of medicine at Credit Valley Hospital in Mississauga, Ontario. He has published over 90 articles in leading journals on respiratory tract infections, and he has contributed to the Canadian and international guidelines on pneumonia and COPD management. With that, Dr. Grossman, the floor is yours.
Thank you, Ian. Pleasure to be with all of you across the country. I guess good afternoon for some and good morning for others. As Ian pointed out, I've been involved with recommendations for treatment for pneumonia for a very long period of time. I was on the original Canadian Thoracic Society Guideline Committee that wrote the guidelines. I was on the very first American Thoracic Society meeting or committee that wrote the guidelines for the US. So I've been doing this for a very long time. And one of the things that I've realized is that despite the best management that we can recommend, there continues to be significant morbidity and mortality associated with pneumonia. And I've learned over the years it's a hell of a lot easier to prevent pneumonia than it is to treat it. So accordingly, a lot of my interest has now switched from recommending antibiotics to try and prevent infection entirely, and particularly pneumonia, which is a major player in the healthcare system. So we're going to talk about the pneumococcus today and talk about advances in vaccination. And the technology that I'll be describing today is okay for today, but I can tell you a year from now, 2 years from now, it'll be different. Things are changing very rapidly. Technology is improving. The vaccines are improving. And the future, I think, looks quite bright. So I have my conflicts listed here. I am on nobody's payroll. I own no stock. My kids own no stock in any pharmaceutical company. So I think I'm reasonably balanced. And what we're going to try and do this afternoon is talk about pneumococcal disease, how you get it, why it's so important, the complications associated with it, identify the people particularly at risk of pneumococcal disease, try and differentiate kids and adults. Even though we're all the same, when it comes to pneumococcal disease, there are very significant differences between young infants particularly and older adults. And then finish up talking about current recommendations for management and how even the current recommendations, I think, are still somewhat inadequate, and we need to make some changes in that. So let me start with the organism itself, the pneumococcus. The pneumococcus is a uniquely human pathogen. The reservoir for this organism is the nasopharynx of little kids. So infants carry this organism. And if your infant is in a daycare center, little infants and kids and toddlers love to share their secretions. They share their secretions amongst themselves. So about 50% of kids in a daycare center will be colonized with this organism. Because these toddlers share their secretions very readily, when the parents come up and pick up the kid and hugs and kisses their children, the child will share the secretions with the parent. But the parent may acquire the organism, but doesn't hang on to it very long because the parent has a very strong and intact immune system. And even if they do get colonized, the colonization tends to be relatively short and there are very few consequences. The problem occurs for grandparents. So I'm a grandparent, I'm at risk. So grandparents, as you will see, are a particular risk because their immune system is weakened as they get aged. And when they acquire the organism from their grandchild, they may not clear it. Their immune system is not adequate to clear the organism, so they carry it. And something like 10% of adults will be carrying this organism. Even then, the organism may not do anything. But then the adult gets a viral infection, influenza, RSV, COVID, parainfluenza. And these viruses essentially damage the host defenses in the airways. And if you are already colonized with the pneumococcus, think of the pathogenesis here as the virus essentially opens up the door and then the pneumococcus walks in and causes disease. The other thing to keep in mind about this organism is that it is not one organism. There are now 100 different serotypes identified. This is an important feature because the serotypes look different from each other and may act differently from each other. And having some natural immunity from being infected with one serotype does not necessarily give you any protection against any of the other serotypes. And when the pneumococcus enters the body, it can do a number of things. I already told you about this carriage that can occur in the nasopharynx and in infants. Particularly in young kids, it can spread into the ears. You get otitis media. Tends to be a real, pain, but mortality is not particularly high. If it gets into the lung, it causes bronchitis, which is a relatively benign condition, but pneumonia is not. It's probably about a 10% mortality associated with pneumonia. And then the real mortality numbers start to rise when you're looking at bloodstream distribution of the organism. If you get meningitis, which occurs particularly in young kids, mortality rates of up to 20%. And if you're unfortunate enough to be septic with this organism, again, mortality quite substantial. So the aged are at risk, and I'm going to show you the data to support this. This is Canadian data from across the country, over 11,000 cases of community-acquired pneumonia, over 200 cases of invasive pneumococcal disease. And you'll note that the majority of cases occurred in people over the age of 50, especially over the age of 65. So that for pneumococcal community-acquired pneumonia, all community-acquired pneumonia, and invasive pneumococcal disease, these are age-driven disorders where people over the age of 50 get it, and particularly those over the age of 65. So why do they get it? So the answer is a condition called immunosenescence. And I hate to tell you, individuals here on this webinar, that once you hit the age of 50, it's a slippery slope after that. So after the age of 50, you get progressive weakening of your immune system. It's called immunosenescence. What happens is the bone marrow doesn't produce as many natural killer cells, antigen processing cells. And if you don't produce these cells, you're not producing the B cells, which produce antibodies, so your antibody levels start to drop. On top of that, the thymus gland, which is important in T cell production, starts to involute as you get older. And with the involution of the thymus, you reduce the number of CD4 helper cells, CD4 killer cells. All of this is called immunosenescence. This process is progressive and it is relentless and it is inexorable. We have no interventions that can alter this process. So the older you get, the weaker your immune system becomes. And we can measure this in certain ways. And if you're the age of 70, your immune system is about half the strength that it was when you were age 35. So age 50, this process begins. We've had vaccines for a while. Protein conjugate vaccines were first introduced in the US in the year 2000, in Canada 2004. And with these protein conjugate vaccines to fight pneumococcal disease in infants and toddlers, we've seen a very nice decline in invasive pneumococcal disease. So in kids, this would be mainly meningitis. So there's been a dramatic fall. But if you flip to the right of this graph, you'll notice that in the adults, we've seen very little change over the years. Those two data points at the very end are COVID years, so everything went away with COVID, but everything's back again. There really hasn't been much of an impact in reducing invasive pneumococcal disease in adults. And one of the reasons is shown in this slide. There's very high vaccination rates in the pediatric population, much less so in the adult population, and particularly poor in the at-risk population who is less than age 65. So that's one of the major issues confronting us going forward is under-vaccination rates leading to more invasive disease, more problems. So besides the age, who else is at risk? Well, clearly the immunocompromised. So these are data looking at invasive pneumococcal disease in the Toronto Peel region in terms of annual incidence per 100,000 people. And you'll notice that in the immunocompromised, the risk goes up 12 times compared to people whose immune system is intact. And the mortality rate of people who have invasive pneumococcal disease and they're immunocompromised is almost double that of individuals who are immunocompetent. On top of that, a wide variety of comorbidities can increase your risk as well. If you look at the far left of this slide, this looks at pneumococcal pneumonia risk stratified by age. So the red column represents individuals over the age of 65, and the magenta column represents individuals between the ages of 50 and 64. You can see there's a clear-cut age increase risk. The risk for the 50-year-old is higher than a 40-year-old, but I'm showing it from 50 and above. But look at what happens when you have chronic lung disease. This is COPD. I mean, the increase in risk for an individual, let's say, who's 70 years of age compared to someone without COPD, that's gone up 8 times. So the increased risk with COPD resembles already someone who's immunocompromised. But look at the other lung conditions that increase the risk, like asthma. Even cigarette smoking without COPD is an independent risk factor. But virtually any chronic disease, chronic heart disease, type 2 diabetes, neuromuscular diseases, chronic renal failure, all of these conditions, alcoholism, all of them increase quite significantly the risk of pneumococcal disease. And on top of that, these risks are additive. So if you're over 65 and you've got COPD and you've got some diabetes, that's 3 risk factors there, and they're additive risk factors. So that person is basically waiting to get pneumococcal pneumonia. The problem with pneumococcal pneumonia is we almost never diagnose it as pneumococcal pneumonia. We diagnose pneumonia. We rarely really identify the pathogen unless you get a positive blood culture, because making a microbiological diagnosis is often quite difficult. So there have been surveys to try and identify how frequently all-cause pneumonia really is related to the pneumococcus. And the tool that's being utilized is a urinary antigen test, which was actually developed by Pfizer to look at their 20-valent vaccine, Prevnar 20. So this urinary antigen test identifies 20 of the 100 serotypes. And in this particular study in Spain, the pneumococcus could be identified as being the causative pathogen in about 1/3 of the cases. And that seems to be the number in Europe. In North America, it's quite a bit less. It appears about 14–15% of all-cause pneumonia can be attributed to the pneumococcus. But these numbers almost certainly are underestimates. Why are they underestimates? Because the urinary antigen test only identifies 20 of the 100 serotypes, another 80 out there that we're not even measuring. So while we say about 15% of all-cause pneumonia is the pneumococcus, I suspect the number is higher than that. And the pneumococcus is the single most important pathogen that we identify in causing pneumonia. Now, one of the problems we've identified is that nature abhors vacuums. And there's a hypothesis that's been developed called the Red Queen hypothesis from Alice in Wonderland. And the Red Queen said, now here you see it takes all the running you can do to keep in the same place. So this is a hypothesis that says if you get rid of something, something else will replace it. You're always going to run faster and faster to stay in the same place. So let me illustrate how that's played out in the arena of the pneumococcus. So this is called replacement disease, and it is essentially this Red Queen hypothesis. So let me show you US data. So before the first protein conjugate vaccine, Prevnar 7, was introduced, the 7 most frequent serotypes causing Invasive pneumococcal disease in children under the age of 5 is shown on the top left of this slide. So serotypes 14, 19F, 6B, etc. In the year 2000, which is this vertical line in the middle, that was the year 2000. That's when Prevnar 7 was introduced. And over the next few years, you'll notice that those 7 serotypes, which were the leading cause of invasive pneumococcal disease in infants, essentially disappeared. A fantastic result. Great vaccine. Those 7 serotypes went away. Not only that, but in adults over the age of 50 who were not vaccinated, those 7 serotypes in the adults also went away. And this is a beautiful example of herd immunity. If you protect the children from disease, remember the children are often the source of disease in the adults are protected as well. This is herd immunity. However, something else happened. So in the subsequent years, you'll notice that there's a line that goes to the right, and it's serotype 19A. So this is replacement disease. Those 7 serotypes were replaced in part, the most common replacement serotype was 19A. And 19A, you can see this here, when Prevnar 7 was introduced, the 7 serotypes, the red lines in children and adults really went down. But 19A, which is the green line, went up, and that basically is the replacement disease. And 19A looks like this. It's an encapsulated serotype, so it's hard to get rid of. The capsule hides the core of the organism from your immune system, so it's hard to get rid of. But on top of that, this organism was an MDR pathogen. It was a multi-drug resistant pathogen. So it was resistant to all of the first-line medications like penicillin, amoxicillin, the tetracyclines, the cephalosporins. The only thing it was susceptible to was the quinolones, and in kids, you can't use quinolones. So that's a problem. So Prevnar 7 had to change. This is an infant vaccine, but it had to change to deal with 19A. So Prevnar 7 graduated to Prevnar 13. And in Prevnar 13, one of the serotypes would be 19A. So this is a concept that you have to keep in mind, this replacement disease. And I'm going to come back and talk about it toward the end when we talk about the new vaccines. So one of the reasons we're really concerned about pneumonia is bad things happen when you get pneumonia. So this is outcomes, again, in Canada, in individuals who get hospitalized with community-acquired pneumonia or invasive pneumococcal disease. By the way, look at the numbers. For every case of invasive pneumococcal disease, there's hundreds of cases of pneumonia without bacteremia. But you'll notice that the older you are, generally speaking, there's more problems. So the mortality rate for the people over the age of 65 is about 1 in 10, lower for the younger people. But you'll also notice that younger people are more likely to end up in the ICU. Let me try and explain this. So individuals who get hospitalized because of pneumonia and they're over the age of 65 often get admitted to hospital. Yes, they have pneumonia, but their other comorbidities are a problem. So maybe their heart failure is a little bit worse, their diabetes is out of whack, their blood pressure goes crazy. So there's other things that may drive the admission besides the pneumonia, whereas younger people who get admitted to hospital with pneumonia are really sick. I think that really explains why ICU admission rates may be a bit higher in people under the age of 65 than individuals over the age of 65, but the mortality rate clearly is age-driven. So what kills them? Well, it isn't overwhelming sepsis, I can tell you that. So septic shock associated with bacteremic pneumococcal pneumonia is relatively rare. What really does these people in are the cardiac complications associated with an acute inflammatory event. So this is one group of studies trying to look at the overall incidence of cardiac complications occurring after the individual has been admitted to hospital because of pneumonia. And the number here is about 14% of people will get some cardiac abnormality. So the commonest thing they get is heart failure. So about close to 10% of people will develop heart failure after they've been admitted to hospital. About 5% of, close to 5% of people will have a heart attack, and about 7% of people will develop an arrhythmia, likely atrial fibrillation. So the scenario goes something like this. The individual gets admitted to hospital with pneumonia. On day 2, they go into atrial fibrillation. With their atrial fibrillation, very rapid heart rate, they go into heart failure. And the day after that, you measure their troponins, and you notice there's a bump up in their troponins, and they've had a subendocardial myocardial infarction. This is very, very common. So cardiac complications are a major issue driving poor outcomes for people who are admitted to hospital with pneumonia. This is, again, a group of observational studies looking at the risk of developing atrial fibrillation. So this is new onset atrial fibrillation occurring after you've been admitted to hospital with pneumonia. And the prevalence is a little over 7% of people, all people coming into hospital with pneumonia will develop new onset atrial fibrillation. And those individuals who do develop atrial fibrillation have an increased risk of dying within the year, presumably of their cardiac disease in some fashion or other. This process is prolonged. These are these are two big data sets looking at the likelihood of having cardiac events after they've had their hospitalization, survived the hospitalization, and went home, and then followed out up to 10 years. So in these two large databases, they were looking for the incidence of myocardial infarction, stroke, or sudden death. And you'll notice the odds ratio in the graph at the bottom. The odds ratio are doubled for these events for at least 2 years in a significant fashion and numerically increased for 10. This cartoon tries to represent this. So what's being plotted here is your risk of having a cardiovascular event. That's heart failure, stroke, heart attack, atrial fibrillation. The yellow line represents viral infections like influenza, RSV. You'll notice that for a couple of weeks, the risk of a cardiovascular event is increased with these viral infections as well. But the risk diminishes over a few weeks. And by the end of a month, more or less, the risk is back to baseline. So they have this vulnerable period of 4 or 5 weeks, but then they recover and they're fine. The blue line represents individuals who have pneumonia and get admitted to hospital, but not in the ICU. You'll notice there the risk is more than tripled. It lasts a little bit longer. And while the risk diminishes over time, it never gets back to baseline over years. And heaven forbid, you should be admitted to hospital with pneumonia and develop septic shock or sepsis, which is the red line. Your risk of a cardiovascular event goes up more than 6-fold, lasts for at least a month and diminishes, but once again, never gets back to baseline, which is why I say to individuals over the age of 50 who get admitted to hospital with pneumonia, forever their prognosis is altered, and is altered because of the risk of developing these cardiovascular events. All of this is related to inflammation. Inflammation triggers a wide variety of things in the cardiovascular system. The sicker you are, the more brisk the inflammatory response, the greater the risk, which is why a septic individual is worse than someone with just pneumonia, and someone with pneumonia is worse than someone with a viral infection. But they all are associated with increased cardiovascular risk. This is a very hot area of interest, trying to understand this. What do we do about this? And the right answer, of course, is don't go there. I mean, if you don't get the pneumonia, you don't get hospitalized, and this sort of thing, generally speaking, won't happen. Okay, so the first protein conjugate vaccine that was used for adults was the 13-valent vaccine called Prevnar 13. And Prevnar 13 basically replaced the old Pneumovax 23. Now, Pneumovax 23 has been around for decades, and there's always been some question as to whether or not it actually works. So I like to show this study, which is the investigators looked at many observational studies and identified 9 studies where the populations for those receiving Prevnar 13 were very similar to the population receiving Pneumovax 23 or PPV 23. And they were looking at the point estimate of effectiveness. The only large randomized prospective trial for Prevnar 13 demonstrated a point estimate of about 45%. There have been other studies a little bit higher. So the efficacy of the pneumococcal vaccine is somewhere between 40 and maybe 80%. You'll notice that the point estimate for Pneumovax 23 hovers around 0. It goes from -10 to plus 11, hovering around 0. And for the longest time, NACI was recommending Prevnar 13 followed by Pneumovax. And you'll notice that the signal for the combined vaccine is exactly the same for Prevnar 13 alone. In other words, Pneumovax added nothing. So that's for proven pneumococcal disease. If you're looking at all-cause pneumonia, remember the pneumococcus is about 15% of all-cause pneumonia. You see a point estimate for the conjugate vaccine around 10%, and the point estimate for Pneumovax hovering again around 0. So it doesn't work to prevent pneumococcal pneumonia or all-cause pneumonia. So we think this vaccine is essentially useless, and it is now off the market. So what about the efficacy of these pneumococcal conjugate programs? So when Prevnar 13 came out, and we looked at large databases, you'll notice that the point estimate of vaccine effectiveness runs around 10%, which is more or less what you would anticipate, a reduction of about 10% to about 10%. For a vaccine that gives you 50% protection of an organism that accounts for about 15% of all pneumonias. So the vaccine works in large populations, safe, but we have problems. And the problems I've already listed: replacement disease. I'm going to focus now on the under-vaccination rates. So these are data going back to 2019, looking at individual vaccination rates compared to what we want. So for participants over the age of 65, which is on the right of the slide, the Canadian target is around 70. We really like to get 80%. As for pneumococcal vaccination for this high-risk group, it's under 60%, and that's an overestimate. It's not actually that, because a lot of those people who have had the pneumococcal vaccine had Pneumovax 23, which really doesn't work. So the number is probably significantly lower than that. But if you look at the left of this slide, these are individuals between 18 and 64 who are at risk of pneumococcal disease, either because they're immunocompromised or on a biologic, bad COPD, bad diabetes. And you'll notice in those individuals under the age of 65, the vaccination rate is appalling. It's only 1 in 4 have actually gotten this vaccine. So huge problems with under-vaccination rates. So this is data going back to 2019. What about more recent data? So this is coming from the government. This is, I guess, 2024. If you look at individuals, combining the individuals who are over age 65 who should get the vaccine, along with individuals between 19 and 64 who are at risk and should get the vaccine, the overall vaccination rate in Canada is less than 40%. So don't be surprised if this organism hangs around and causes more grief going forward. We have a big problem here. So the solution for replacement disease, that is these other serotypes coming in, is more. You have to give more coverage with a bigger serotype coverage in the vaccine. So Prevnar 7 graduated to Prevnar 13. Prevnar 13 graduated to Prevnar 20. And the gap between the introduction of one to the others in the ballpark of 6 or 7 years is the time frame where you start looking at different vaccines because of this replacement disease going on. And so newer vaccines have been developed. And I want to point out that adults and children are not the same. So this is the serotype distribution in a pediatric population on the left and an adult population over the age of 65 on the right. The yellow circles represent serotypes that are common for both. The size of the circle represents how frequent that serotype is in causing invasive pneumococcal disease. So on the left, the bluish colored circles are serotypes that are unique for infants and children. And the green ones, circles on the right, are the ones that are unique for adults. They are not the same. Some are, but clearly there are unique serotypes for both children and for adults. The vaccines that we have available have essentially been built on Prevnar 7, which was designed for infants. So you see on this slide at the very top, PCV7, those are the 7 serotypes that were in the original Prevnar 7. And that graduated to Prevnar 13, where they added on 6 serotypes to the original pediatric vaccine. And then PCV20 or Prevnar 20, they've added on another 7 serotypes to the original vaccine that was developed for infants. Merck took a very different approach to adult vaccination and said, well, look, adults are not the same as kids. Why are we giving an infant vaccine to adults? So they developed, they took a very different path, a different strategy to develop their new vaccine, which is called V116. And the name for that one, trade name, is Capvaxive. So what they did was they got rid of the original 7 that were in Prevnar 7, 13, and 20. The notion being there's probably herd immunity against those serotypes. They don't really circulate very well for the most part. And many people have already received either 13 or 20 and have immunity against those 7. So what they did was they got rid of those 7, but they added in 8 unique serotypes that are only found in adults. And those are the blue ones you see in the bottom right of the slide. So V116 is a very different vaccine than the 20-valent vaccine that Pfizer has developed, which is Prevnar 20. So people think, well, 21 and 20 must be the same, but they're not. They're completely different. So V116 or Capvaxive adds 8 new serotypes that is not in Prevnar 20. These are the approved vaccines in Canada. So Prevnar 13 no longer is being promoted. Pneumovax 23 is no longer provided because it's essentially useless anyways. The current routine childhood vaccine, at least in the province of Ontario, is a 15-valent vaccine developed by Merck called Vaxneuvance. So it's basically Prevnar 13 and 2 other serotypes. Prevnar 20 you're all aware of. It's the one that's approved and funded in the province of Ontario. And the new kid on the block is the 21-valent Merck vaccine called Capvaxive, which is approved by Health Canada, and it is another option to Prevnar 20. Now, if you look at the serotype coverage of Prevnar 20 and Capvaxive, they're different. The data on the left applies to individuals over the age of 65, and the data up to 2023 would suggest that individuals who receive Capvaxive, that will cover close to 80% of all the strains that are causing invasive pneumococcal disease in adults over the age of 65, whereas Prevnar 20 will cover about 65% in that ballpark of the strains causing invasive disease as of 2023. The delta is 14% in favor of the new vaccine. So Capvaxive will have 14% more coverage of the known serotypes causing invasive pneumococcal disease in individuals over the age of 65. The reverse is actually true for people under the age of 65. There's an advantage for Prevnar 20. It will cover more of the serotypes causing invasive disease in people under the age of 65 than will Capvaxive. So there's a clear cutoff around the age of 65. So NACI in 2024, which is their latest recommendations, basically said that either Prevnar 20 or Capvaxive would be okay. They've approved one or the other, and you give one or the other, regardless of previous pneumococcal vaccination history, and they're recommending it for everybody over the 65 or older, and anybody under age 65 who's at increased risk for invasive pneumococcal disease. So the 55-year-old individual with bad COPD, the 45-year-old woman with rheumatoid disease on a biologic, cancer chemotherapy agents, immunocompromised, et cetera, all should be vaccinated with either of these 2 vaccines. In the province of Ontario, Ontario is a real leader in coverage for vaccines. In fact, they were the first jurisdiction in the world to provide free coverage for RSV vaccine, for example, for a certain group of a certain part of the population. So this is what's going on in the province of Ontario currently. So for infants, the routine 3-dose regimen is with the Merck 15-valent vaccine, Vaxneuvance. So 3 doses. For high-risk children, because the risk of some of these more unusual serotypes, the recommendation would be to give Prevnar 20. For adults between the ages of 5 and 64 who are at high risk, the recommendation would be to give Prevnar 20. And that makes sense because these individuals tend to be more like children than older adults. The routine program in Ontario for adults over the age of 65 is also for Prevnar 20. It's provided for free, but I'm not sure this is the right decision. So this is the serotype distribution, the latest data that we have as of last year, so 2024. And you'll notice in individuals over the age of 65, the delta, remember I said before the delta was about 14%. That was data from 2023. This is now data from 2024. The delta still is in that same ballpark, around 13%, in favor of Capvaxive over Prevnar 20. Because of this advantage of Capvaxive over Prevnar 20 for adults, recommendations are changing. You'll notice also in this slide, the reverse is true for the younger individuals. There is an advantage for Prevnar 20 for the younger individuals over Capvaxive. So there's a committee, an advisory committee in the province of Ontario called the Ontario Immunization Advisory Committee. And in May of this year, this is the recommendation they made. So the committee recommended the new Capvaxive vaccine, the V116, the Merck vaccine for people 65 years of age or older, but recommended Prevnar 20 for the individuals between 18 and 64 who are at increased risk of invasive pneumococcal disease. So the recommendations are starting to change, but the funding hasn't followed the recommendations. And that's one of the other issues that's going to come up. So going forward, what are we going to look for in the new adult pneumococcal conjugate space? Because there are new vaccines coming. And in this space, what we're going to be looking at is ongoing epidemiologic studies to identify the serotypes causing invasive pneumococcal disease and community-acquired pneumonia. On top of that, are these serotypes really important? Are they associated with invasive pneumococcal disease? And then finally, are the serotypes that we want to prevent organisms that are multi-drug resistant organisms, which for sure we would like to prevent. So there's a number of different issues here that will drive the construction of these vaccines going forward. One of the biggest gaps in our knowledge is the serotype distribution for ordinary community-acquired pneumonia. We have pretty good data for invasive pneumococcal disease, but for ordinary community-acquired pneumonia, we just don't have really good data regarding the epidemiology of the serotypes. So if I can conclude, the pneumococcus continues to be the most important bacterial pathogen leading to pneumonia and a variety of other conditions, invasive pneumococcal disease, meningitis, bacteremia, septic shock. The elderly for sure are at risk, the immunocompromised at risk, and virtually any chronic condition, especially respiratory ones, so COPD, asthma, cigarette smoking, will increase that risk quite dramatically. The big concern about pneumococcal disease or pneumonia in general is this association with serious cardiovascular complications, particularly when you get really quite sick with your pneumonia. Your risk of having heart attacks, heart failure, stroke, and atrial fibrillation goes up quite dramatically. We have pretty good evidence that our current vaccines are effective. There's only been one prospective randomized trial, which was with Prevnar 13. There are no prospective trials looking at outcomes for Prevnar 20 or Capvaxive. The approvals are based on immunologic grounds rather than outcome trials. But we know that replacement disease is a challenge. Every few years, new serotypes will show up, and we're going to have to keep on top of the situation, trying to identify which serotypes are circulating, and then alter our vaccines accordingly. As a general principle, more coverage is better than less. We want to cover more of the serotypes. The problem is there's technical issues. I mean, how big a shot you're going to get, how many serotypes you can put in there. There's some interference when you put in a whole bunch of serotypes. The immune response tends to be a bit blunted against some of the serotypes. We do have newer vaccines with better serotype coverage, like Prevnar 20 and V116 or Capvaxive. There are more to come in the next few years, and we still need to kind of better define their role. And at the end of the day, the coverage isn't following the science. So while advisory boards may say people over the age of 65 should get the adult vaccine, which is Capvaxive, the government's not paying for it yet. And I think we need to make some changes there as well and argue with providers in the public health space that these are better vaccines, better coverage, and there's a huge advantage in using them. At the end of the day, let me just finish with sort of a mini editorial, if you will. Our healthcare system uh, almost always is verging on a collapse. We saw it with COVID. When we were overwhelmed, the whole system collapsed. And every winter in Canada, we run into problems from Christmas on through the end of February, where there's always a crisis in the hospital system because of overwhelming admissions with lower respiratory tract infections. Listen, I was the chief of medicine for quite a number of years, and every year we had to cope with this. We were converting our library into hospital beds. We had people in stretchers in the halls, without bathrooms and showers. It was awful. And every year we run into the same problem. And when you think about our system going forward, as the population increases and the population ages, the burden of disease will get more and more. And more individuals, as they age and their immune system weakens, will be vulnerable to these respiratory infections. So if, unless we, in general, adopt these new technologies, our system's in real trouble. The advantage of vaccination as a new technology is it favorably affects the healthcare system. You reduce respiratory infections, you reduce admissions to hospital and the concomitant costs and morbidity and mortality associated with it. We need to be very aggressive in accepting these new technologies, promoting these new technologies. Otherwise, I think our healthcare system in the long run will not survive. So thanks very much for your attention. I'd be more than happy to answer any questions. I'll turn it back to Ian.
Thank you very much, Dr. Grossman. Great presentation, and certainly lots of information for us all to be considering. We do have a couple of questions already, and this is building on one of the points you made in your conclusion. An attendee wrote, I understand the importance of developing higher valence vaccines. However, there are risks associated with developing these vaccines, including potentially facing interference in the immune response by the increase in molecules. Due to this potential limitation, is there anything else that can be done in terms of vaccination?
So the general principle is more is better than less with some technology limits. So if you put, 100 serotypes in a vaccine, the needle will be, so big, it'd be huge. And you try and stick that in an arm, good luck with that. But on top of that, the immune response tends to be a bit blunted if you add in more and more serotypes. There are new technologies coming, new platforms where antigens can be placed on a new platform and you can give multiple antigens in one go round. So the technology is coming. It's not that far away. There's one platform called the MAP platform, which is a multiple antigen processing platform, MAP. I think GSK bought that platform and they're producing a pneumococcal vaccine, and other vaccines will be on that platform as well. So there are things coming that I think can overcome some of the issues that were just raised.
Excellent. So, of course, you're not giving medical advice during this webinar, but there is a question which we're going to make a little bit more generic. Perhaps someone has received the PCV20. Would you recommend that they also get the cap vaccine?
Capvaxive.
Capvaxive,
So
sorry, yes.
I just did it for myself and for my spouse. So the answer I would say is yes. No one's talking about this, but nobody yet. They're saying either Prevnar 20 or Capvaxive for people over the age of 65, but I think you should get both. Many people have had Prevnar 20 in the last couple of years. It's been around for a couple of years now. So it's perfectly safe to get the second one because it's going to give you coverage for an additional 8 serotypes. When you went from 7 to 13, that was 6 additional serotypes. That was enough. And 13 to 20 was 7 additional serotypes. And this one is 8 additional serotypes. So if it was good enough to go from 13 to 20, why isn't it good enough to go from Prevnar 20 to Capvaxive, the 21 valent? Because you're actually adding in 8 new serotypes. And if you had 20 in the past, those 7 serotypes that were taken out, you've been immunized against those, and you have probably lifelong protection against those. So I think it makes eminent good sense, but no one's saying anything yet. Nobody, except me. And I put my money where my mouth is. I bought the vaccine. I got it for myself. I got it for my spouse. I'm telling all my friends, get protected. More protection is better, and
Excellent.
it's safe.
Well,
There's no problem. There's no safety issue at all with this.
perfect. So in the same lane, one participant is asking, why would NACI say either P20 or P21 for 65 years and older, while the data clearly shows that P21 will have far better coverage for this age group?
Um, I hate to say this, but NASI is almost always a day late, a dollar short. So a day late for sure. The data for these vaccines have been available for a while. When pneumococcal vaccine Prevnar 13 came out, which was back in 2014, the CDC approved the vaccine within weeks of the publication and recommended it. And NACI took 2 years to say anything, 2 years where the data was available and they did nothing. So NACI is a volunteer organization. They're not full time. They take their time, so they're kind of late, and they're very conservative. So, as I say, a day late, a dollar short is a common outcome from NACI.
There you go. Another question is, how many years after the introduction of a new PCV vaccine in a childhood program does it take to stomp out those vaccinal stereotypes in the child reservoir, assuming near perfect coverage in children?
Well, the decline is pretty quick. So you start seeing the impact within a year or two. So the broader the coverage, the more rapid the decline in those serotypes. But as I say, replacement disease will occur. We know it's going to occur. That's that Red Queen hypothesis. And the gap is usually 6, 7, 8 years before you really need something different. It's not that the original vaccine loses its effectiveness. It does not. It is still potent in protecting against the serotypes that are in the vaccine. The problem isn't that the vaccine doesn't work. The problem is there's new serotypes where there's no protection. Remember, there's no cross protection for these other serotypes from the vaccine that let's say the vaccine is Prevnar 20. There are 80 other serotypes out there that could potentially move in for which you have no protection. That's the problem.
There you go. Um, so I'm going to read this one. This is the my lack of knowledge on this. So I'm going to read this directly. Hopefully you can understand it. With replacement, is the overall is incidence now lower despite replacement, stayed the same with new serotypes, or increased as a result of replacement?
So in infants, there's no question that the incidence of invasive pneumococcal disease has gone down. In contrast, in adults, it hasn't really changed very much. We still see lots of disease in adults. Part of it is because not enough of the adults have been vaccinated. I think that's a bigger part. And then replacement disease is another issue as well. So until unless we get the numbers up for the adults, remember what the target in Canada is, 70 to 80%. We're nowhere near that. So until unless you get near that, you're not going to see a major decrease in invasive pneumococcal disease in adults,
Excellent.
but we have seen it in children, no question.
Right. So Curtis May is asking, can you comment about having only one publicly funded PCV vaccine versus multiple, different for children and adults,
Yeah,
to
I think there
reduce?
should be, I think
Okay.
they should be funding both because it's a something that we do commonly. Let's say for influenza, we have different vaccines for people over the age of 65 compared to people under the age of 65. It's a high dose influenza vaccine. So it's an age-driven recommendation for influenza vaccine. Why can't we have an age-driven recommendation and coverage for pneumococcal vaccine? Makes eminent good sense to me. I would certainly recommend that.
I think that question has already been answered. Would you suggest that adults Over 65 years of age who have had PCV 13 wait for PCV 21 rather than immediately get PCV 20.
So I think they should be vaccinated, period. So if you can get 20 and somebody else will pay for it, great, get it. If money's not an issue or you have private insurance that'll cover it, 21, I think would be a better choice. So it's obviously an individual decision and what they're prepared to pay. Let me make another sort of editorial comment, if you don't mind. It has to do with the value of vaccination in general. So many people in North America have life insurance. They buy life insurance, maybe term insurance or whole life insurance, which costs thousands of dollars when you add up the lifetime of coverage that you have. And it's not really life insurance. Basically, what you're buying is the notion that when the individual is dead, their spouse or children will have something to live on. It's not really protecting your life. You're buying money or payment for your family. But vaccine is truly life insurance. When you buy a vaccine, you're protecting your life. It's the real definition of life insurance. Vaccines are the cheapest life insurance you could possibly buy, period. It's unbelievably cheap. $130 will give you a vaccine once in a lifetime. That's all you need to do it. It's unbelievably cheap. Crazy not to get
Absolutely.
it.
Um, Absolutely. I agree completely. So, next question is how long should one wait to get PCV 21 if you've previously gotten PCV 20?
I mean, theoretically, you can get it the same day. Most people will likely wait. If you're reasonably conservative, probably a year. It'd be no issue whatsoever if you waited that period of time. But off the top, you can get both the same day. It really wouldn't be an issue.
Okay.
But be conservative, wait a year if you've had it.
Okay. Richard is asking, is mRNA technology likely to be helpful with pneumococcal vaccines?
I'm not aware of an mRNA pneumococcal vaccine yet. So, as I say, there are other platforms being developed, but not mRNA for this one.
Very good. Um, if you are younger than 65, say 50 plus, would Capvax, why I cannot say it, the PCV
Capvaxive.
21 Capvaxive, that's it. I have the emphasis in the wrong place. Be better than Prevnar 20 while waiting on the next new technologies.
No. So under the age of 65, the evidence would suggest the serotype distribution is in favor for Prevnar 20. So I sort of said it before, I think there should be an age-based recommendation. Over 65, I think Capvaxive or V116 is better. For under the age of 65, with or without these, well, obviously with comorbidities, then PCV 20 or Prevnar 20 would be better. There's a better distribution. So both I think are useful, but I think an age-based recommendation makes very good sense.
Excellent. Well, we have another age-based question. Why is the burden of IPD disease in terms of serotypes so different in the 50 to 65-year-olds versus 65 and plus? Is it immunosenescence alone?
Um, well, it also depends on the nature of the serotype. So let me try and explain this. So the pneumococcal serotypes look and behave differently from each other. Some are very tiny, do not have a capsule, and are designed to slip in between cells and are often invasive. But because they don't have a capsule, your immune system identifies them pretty readily and deals with them, and they're not really bad. The ones that are really bad are the encapsulated serotypes. So 19A, the one that I was talking about before in kids, particularly serotype 3, have very large capsules. The organism spends an inordinate amount of energy to develop these capsules. So why is it spending all this energy to develop the capsule? Because the organism hides inside this capsule. It's designed for colonization. So if you have this big capsule, your immune system doesn't see the antigens of the organism and does not mount an immune response. So this is a one way of the organism hiding in plain sight. So it's encapsulated, your immune system doesn't see it, it just kind of hangs around. So it's a colonizing strategy. However, if you get a viral infection and you damage the epithelium of the airway, as I said before, that's essentially like opening up the door and allowing the pneumococcus to get in. And if the pneumococcus that gets in is one of these colonizing agents with a big, thick capsule, your immune system doesn't see it. And it's in the bloodstream before you know it, and it'll kill you. So the organisms, it's rather counterintuitive, but the organisms that are designed for colonization, if they get into the system, will kill you. But the ones that are designed to be invasive, your immune system recognizes and handles it very easily. So mortality rates are driven in part by the structure of the serotype that's involved.
Excellent. Well, that is it for our questions for today. So I will thank you once again, Dr. Grossman, for educating us today and giving us all this valuable information on pneumococcal disease. Just a reminder to everyone that today's session was recorded and will be available on CPHA's YouTube channel. All registrants will be notified when it is available. And with that, I thank you all for attending today and wish you a very good rest of your week. Thank you.